Good day, and thank you so much for joining my presentation today. I'm going to be talking about story building as an analytical tool in qualitative evidence synthesis, or as we know it as QES. My co-authors are Karin Hannes and Taryn Young, and also Prof. Kathy Matai, who has passed on last year. Our thoughts are with her, and we also acknowledge her as part of the conception of this paper. So today I'm first going to situate the QES and give you a little bit of background into what it is that we did. Then look at the theoretical lens we use to synthesize the evidence. And then moving along to how we actually got stuck when we started analyzing what we found in the papers. And then the analytical alternative that we came up with, which is I'm going to show you how we move from a stack of journal articles to our storyboard that visualizes our data and our findings and interpretations. So our review aim was to look at the experiences of treatment adherence for young people with perinatally acquired HIV in low to middle income countries, and to understand that we use a very general model of understanding health called the biopsychosocial approach, which is a model developed by Professor Engel. It includes 3 dimensions: biology, psychology, and social context. And taking into account these 3 dimensions, it's easy, or was assumed to be easy, for a medical practitioner to understand the patient experience. So you can see under biology, we've got things like physical illness, disability, genetic vulnerability, stress, medication effects, and how it affects the body. And in psychology, we've got behaviors, personality, emotions, coping skills, and past traumas. And then in the social context, we've got social support, family background, cultural traditions, socioeconomic status, and then education. So we use conventional research methodology to identify the inclusion criteria for our study, meaning when we looked at all the existing evidence, we looked at qualitative studies that had been published, and those qualitative research studies had to include young people with perinatal HIV infections between the ages of 10 to 25 years. It had to be published between January 2006 and November 2021. It had to be in the databases and reference lists and be considered a primary study. And we also did the screening and data extraction independently and in duplicate, meaning there were 2 of us or more that looked at the papers by ourselves. We wrote down what we saw, and then we compared notes with one another. What we found is 1,059 records that matched the initial search, and we searched through the search engine using the databases. When we screened all of those articles, we identified 53 of the articles that matched our inclusion criteria. So these 53 had passed the full text screening, it had passed the abstract and title screening, and it had passed both 2 or more authors when looking at the review. About other elements that are considered material, like for example, the needle that you use to draw the blood, the doctor's office, the clinical coat, the hospital room, the way you walk to the clinic. And these are things that really hadn't emerged yet from the literature. So as we discussed, we proposed a more progressive theoretical lens to synthesize evidence on complex phenomena. And we really embraced the idea of spaces, things, and materialities in the review. The theory that we decided to go with was new materialism, and it fit very nicely with what we are doing in the participatory arts-based research at the moment. The new materialist lens really challenges the purely linguistic approach or the focus of text as evidence or generating meaning out of text. Traditional QES is focused on revealing systems of thought from humans. In other words, it puts the human central to inquiry and it is the human that acts upon the environment or an object and not the other way around, which, as we just discussed, objects really do act upon us as we act upon them. So the analytical principles we used to synthesize the evidence from a new materialist perspective was one, that it was non-linear relationships that we were trying to describe. Principle two, it's always dynamic and in a state of becoming. Principle three, that things, people, ideas, structures can all both affect and be affected. Principle four, there's a flat ontology starting from the events rather than actors and factors that influence as commonly used in QES. And then lastly, principle five, it's analytically diffractive rather than linear and hierarchical. So let's look at synthesizing multimodalities using story. So the 6 steps that we followed was first to familiarize ourselves with the included studies. We extracted the codes and quotes inductively. Then we derived themes from the codes. So we took all the codes we identified and we grouped them together into larger themes. We then identified and extracted material markers relevant to those themes. And a material marker is an actual physical item that is mentioned in the paper. So for example, somebody says my jeans pocket is where I hide my pearls. So the theme may be secrecy and then hiding the pearls in the jeans pocket. The pocket is the material marker that is associated with that. And we then created an image of meaning with narrative interpretations. So then I would draw an image of the jeans with a pocket and narratively describe what we derive from the data. We then synthesized all these little images of meaning into a large storyboard. That's an example of an image. When a kid first finds out about the HIV status or they're taking medicine, they might have lots of questions for parents, and this is where we start our story. Mom, why am I taking all of these medicines? I'm not sure what it's for. Am I sick? And the mommy is so confused. She's not sure. Should I tell her? Should I tell him? Should I wait until he's older? In some instances, parents don't have the opportunity to tell kids, and kids might suffer from loss of parents. Now, when parents pass away, they start thinking about, why did my parent die? Why am I still going to the clinic? And they might be going with guardians to the clinic, unsure about what they are doing there. I go to the clinic all the time. Why is that so? There are so many people at the clinic. I see them standing outside. They're judging me. Why am I at this door that says HIV? I've been to the office and I see the nurse and she's holding this huge chart. And on this chart, she's telling me that I need to take a test. What is this test for, Mommy? Can you please explain? Can somebody please explain to me what's going on? The nurse says, I'm sorry, my dear, I think you have HIV. What? What does that mean? Am I going to die? Am I going to die like my mom or my dad? What about my friends? They are going to make fun of me. People are going to laugh at me. Can I still go to school? Can I still play with everyone? What am I going to do? I know people come to the clinic when they're sick. I know people who are very sick with HIV and they don't have lots of friends. And as the kid gets older and starts becoming more familiar with treatment, they start being more hopeful as the treatment starts to work. Support and motivation from family members and friends really benefits them. And if there is a family member who's HIV positive and adheres, it's really a positive role model. And they say, I don't want to give up on my dreams. I have the support of my family. I want to move towards a better life. There is things I want to do. There's a career that I want to follow. But with all of that going on, I'm so quiet. Shh. I can't talk to anyone. I'm trapped in this box of being an HIV positive person. I have marks on my face. How am I going to deal with the side effects of the tablets? In my environment, I have to deal with walking to the clinic. It's far, it's dangerous. There are religious institutions. I can go to my church. There's solace there. I feel like I'm invisible. At the same time, I feel like I am visible to everybody because of my status. It costs money to go to the clinic. I don't have money. People are going to find out my secret. My pill box is so big. Where do I hide it? I could hide it in my pants pocket. Sometimes I can't take my pills because I don't have food. I don't have enough money. I have to think about the clinic, food, tablets, missing work. My relationships are so affected by my status. I don't know if I should tell my partner. What if my partner doesn't want to use a condom? What if I have to prove that I love him or her? I remember when I was in the boarding school, I used to hide my tablets on the side table next to my bed, sometimes in my pants pocket, where no one could find it and I could take it undercover. Sometimes I'd go to the toilet and I'd take it there where no one would see me. Life is filled with decisions, fear, stigma, in all kinds of spaces and time, whether it's on the road to the clinic, public transport, at church, in my family, at school. There's so many issues to deal with, and I negotiate secrets all the time, weighing the cost of health over social and economic constraints. This is a whole embodied experience, a multi-sensorial experience, both within me and outside of me. Adherence to my medication is not as easy as storyboard, which then can be either made digital, added to the review as the results and the findings. And it's also been really useful for me to use with participants. And I show them, this is what I found from the data. Where can you add, or is there something that's incorrect, or is there something that really speaks and resonates with you, which is much easier to interact with participants in primary studies and in the community research than a piece of paper or a presentation would. What we've learned is that the power theory that supports the QES should be that it makes you discover more of different layers of a particular phenomena, that using a theory such as new materialism does something different than the use of logic models or categorization, and that the way we tend to represent relationships in systematic reviews is perhaps too limited to fully grasp the entangled nature of phenomena such as adherence. Future research really needs to ask what matters when it comes to studying complex healthcare topics in a multi-genetic world, and how it reconfigures the assemblage of people's experiences, ideas, perceptions in relation to our social identity. How can the idea of assemblage and entanglement best be transferred to a synthesis level is a question that we really need to ask to increase understanding of our results by a broad variety of stakeholders, both in terms of the analysis and in terms of representing the findings. How valid are the findings, or how to best judge the quality of the outcome, the feasibility of the method, what if I can't draw, is this method for me, and how to move from concrete drawings to abstract theories. So I really challenge you to think about your own primary study even, and how you would use data from your participant, from your interviews, to create the storyboard. And then if you work on the review level, how to integrate and synthesize the findings from multiple primary qualitative studies. I'd like to acknowledge those who assisted me with this review, Susan van Wyk and Nico Kanoy, and then also the supervisors for providing critical comments. And I'd also really like to thank the funders of this project, the Global Minds PhD Fellowship at KU Leuven, and then also the REGIT project that's funded by the London School of Tropical Hygiene for supporting the development and implementation of this review project. Please feel free to connect with me via Twitter at research_ambit, or send me an email at lina@sunac.za, or chat with me on Miro through this conference. And let's talk about what's the one thing or thought you take away from this presentation that might change the way you look at your evidence. Thank you for listening. Enjoy the conference and hope to meet you all soon, sometime in the future.